Hello, this is Dr. Amy Beltwell. I am the co-principal investigator of the Agency for Healthcare Research and Quality's Reducing Medicaid Readmissions project. I'm pleased to welcome you to the first webinar in a 6-part webinar series to support the dissemination of the Hospital Guide to Reducing Medicaid Readmissions, Designing and Delivering Whole Person Transitional Care. The agenda for this webinar is as follows. We'd like to provide an introduction to the ARC Reducing Medicaid Readmissions project. We'd like to provide an overview of the Hospital Guide to Reducing Medicaid Readmissions, and provide an introduction to the framing concepts of the guide and the methods we use in the guide, including why focus on Medicaid readmissions, why take a whole person approach to improving transitional care, and why take a data-informed approach to reducing readmissions. The objectives of this webinar are the following, so that users of the guide will understand the purpose of the ARC Hospital Guide to Reducing Medicaid Readmissions, understand the focus on Medicaid as a catalyst for promoting whole person care for all high-risk patients, and so that users will understand the guide's ASPIRE framework as intended to support a data-informed and strategic redesign of your hospital's readmission reduction efforts. By way of brief background, the ARC Reducing Medicaid Readmissions project was born of an observation that readmission reduction efforts to date have largely been informed by research on the older adult Medicare population. That CMS payment incentives focus hospital teams on the Medicare population, and this has been achieved through a variety of effective incentives in the field, such as the Medicare Readmission Penalty Program, the Community-Based Care Transitions Program, Transitional Care Management Billing Codes for Medicare Fee-for-Service beneficiaries, the proliferation of accountable care organizations, as well as bundled payments programs. And so we asked the question, to what extent are Medicare patients the only patients at high risk of readmission? And does a focus on Medicare beneficiaries create any sort of trickle-down or halo effect that would benefit all patients, including all other high-risk patients? Our project has been underway for the past 5 years and has progressed through a series of phases. In the early phases, we sought to identify the factors at the patient, provider, and system levels that contribute to Medicaid readmissions. We then moved into a phase to explore the extent to which the best practices to reduce readmissions that were in the field applied to the Medicaid population. We then created version 1 of the ARC Hospital Guide to Reducing Medicaid Readmissions to increase awareness of the unique issues involved in reducing Medicaid readmissions, and version 1 was published in 2014. We moved into a field testing and dissemination phase where by where we tested and evaluated the guide through dissemination in learning collaboratives and direct implementation coaching in high-volume Medicaid hospitals to assess the feasibility and implementation of the recommendations in the guide. And based on that work, we now bring to you an updated version 2.0 of the guide. I'd like to acknowledge the numerous partners involved in developing this work over the past several years. First and foremost, I'm indebted to the research team at John Snow, Inc., my colleagues James Maxwell and Angel Burgoyne, in addition to Katie DeAngelis, Sarah Danetti, Michelle Savuto, who have been invaluable collaborators in producing this work over the past 5 years. I'd like to also acknowledge the guiding and supportive influence of Dr. Joanna Jang, our program officer and a senior social scientist at the Agency for Healthcare Research and Quality. And this work would not be possible, nor would it be in this final form without the generous contributions of our hospital partners, as well as hospital association and quality improvement partners who have supported the testing and dissemination of the guide over the past several years. The current version 2 of the Hospital Guide to Reducing Medicaid Readmissions is here on your screen, subtitled Designing and Delivering Whole Person Transitional Care. You can see the table of contents, and this webinar series will walk us through the various chapters in the table of contents. The guide is accompanied by 13 tools that are intended to be feasible and practical tools for hospital-based readmission reduction teams. And again, throughout this webinar series, we will present to you the various tools as they correspond to the ASPIRE framework. The ASPIRE framework is an acronym that captures the core recommendations of the Hospital Guide to Reducing Medicaid Readmissions. You will recognize that this is presented to you in the form of a driver diagram. A driver diagram is an increasingly common tool in quality improvement to help identify the theory of change of a large-scale improvement effort. And as we worked with teams and tested the recommendations, we identified that while many toolkits focus on the action, specific actions, specific best practices, tools and tips to achieve that, we wanted to take a step back and help teams focus on really designing a data-informed portfolio of strategies in this, and represented here in this analysis primary driver. That we observed many teams have been testing and implementing changes based on market incentives, and as the market continues to evolve and as our focus on reducing readmissions moves from Medicare into Medicaid, into whole population areas of focus, we encourage teams to take an opportunity and to work through the analysis components of this guide to update and broaden the scope of readmission work in your organization. Second, we observe that hospitals that have hospital-wide readmission reduction results have action elements that span the best practices, but really focus on a minimum of 3 essential components of work. And those are captured in the last 3 elements of the ASPIRE framework. We observe that successful hospitals improve standard transitional care processes for all patients, that they collaborate, reach out and collaborate with providers and agencies in the community to improve handoffs, to better link patients to the services and supports that exist outside the walls of the hospital. And finally, that hospitals with success identify that the best transition out of the hospital and reception into the next setting of care does not suffice for some very high-risk patients, and that delivering enhanced services post-hospitalization in the days to weeks following a discharge is really essential to helping them avoid a readmission. And so the ASPIRE framework is an acronym that can help your team remember the 6 components of this data-informed and strategic redesign model: analyze data, survey your current readmission reduction efforts, plan a multifaceted data-informed portfolio of strategies, implement whole person transitional care for all, reach out and collaborate with cross-continuum providers, and enhance services for high-risk patients. So why focus on Medicaid readmissions? Over the past several years, as you have all experienced, the Center for Medicare and Medicaid Services has highlighted and encouraged hospitals to work on reducing readmissions. And it's our observation that there are at least 6 foundational messages that CMS has propagated through policy, programs, technical assistance, and other demonstration initiatives that they've funded over the past several years. First and foremost, through the penalty program and value-based purchasing program and other financial incentives, we in the field have received the message that reducing readmissions pays, or at the very least, a failure to improve can hurt hospitals financially. They have sent a message that hospitals must improve standard discharge planning processes for all Medicare and Medicaid patients, that reducing readmissions is, in fact, a cross-continuum effort, and through the QIO program and other demonstration programs, CMS has specifically encouraged senders and receivers of patients across care settings to better collaborate in improving care across the continuum. CMS has sent the message through various programs that attending to non-clinical needs for post-hospital support and services is as important as a clinically astute transitional care plan, and that services and supports need to be in place in order to help patients recover and recuperate in their next setting of care. CMS has been a champion of promoting shared learning as a valuable quality improvement tool through the Hospital Engagement Network, Partnership for Patients work, as well as the QIO efforts to bring together communities of providers to share in learning and action networks. And finally, CMS has been a champion of bringing to the field better and better data, more informative data to help inform our efforts and update our efforts to reduce readmissions, most notably through the QIO program by producing a variety of timely and updated analyses that help providers see where patients are going, where patients are coming back to us from, and slicing and dicing readmission data in very helpful ways. So while all of these messages have come out and been very, I think, influential in improving readmissions for Medicare beneficiaries, we might ask the question, although these messages have been very helpful to the field in Medicare, has any of this work and effort derived benefit to the Medicaid population? So it's possible, likely probable, that this focus has created some blinders. And in the spirit of acknowledging and being grateful for the work and the influence that the Medicare focus has created for all of us in the field of reducing Medicaid readmissions, or excuse me, in reducing readmissions, we see that there have been some blinders from what we'll call this first phase focus on Medicare readmissions in particular. So if you think about your work in your hospitals or in your region, you'd probably acknowledge that the Medicare penalty program has created some blinders we should acknowledge, that by and large there is quite a focus on the Medicare population in readmission reduction work, and our work and our advisement to you in the field is that Medicare patients are not the only patients at high risk of readmission. In fact, older adults are not the only adults that are at high risk of readmission. And that as a payer group, Medicare beneficiaries may not actually have the highest readmission rates of all payer types. And what we have found is that adult non-obstetric Medicaid patients have readmission rates as high or possibly even higher than Medicare beneficiaries. So let's not only focus readmission reduction work on the Medicare beneficiary population. The second domain of blinders that we may have experienced so far in readmission reduction work in the field is that the penalty program has focused us on a limited number of diagnosis-specific patient groups. And so you all know these well. They are the discharge diagnoses for which the Medicare readmission penalty program is based. And when we consider heart failure, heart attack, pneumonia, COPD, hip knee replacement, et cetera, when we consider that list of discharge diagnoses and look at all-cause readmission data analyses, we see that these 6 or now 7 conditions are not actually the top leading diagnoses resulting in the most readmissions for Medicare. They're not even the diagnoses with the highest rates of readmission. And so what we'd like to encourage through the ASPIRE framework, especially the analytic component, is a reconsideration of who is high risk of readmission at your organization, and to think about the facts and the finding that patients with readmission risks are not limited to patients with the penalty condition diagnoses, and to reflect on whether a case-finding approach has helped improve care overall at your organization, or whether it has balkanized readmission reduction efforts into disparate pockets of work instead of supporting overall delivery system transformation, which is part of the path to accountable care and value-based care. So why encourage you to look at your Medicaid readmission rates? We have found that Medicaid patients have high readmission rates. When we look at Medicaid all-cause readmission rates for patients in the younger adult category, ages 21 to 44, their all-cause 30-day readmission rate, 19%. When we look at Medicaid all-cause readmission rates for the middle-aged adults, ages 45 to 64, their all-cause readmission rates, 21.6%. And this, as you can see on the screen, is higher than the all-cause Medicare readmission rate nationally at 17.3%. When we just look at the condition that we most often associate with work in readmission reduction, heart failure, we see that Medicaid heart failure readmission rates are actually higher than Medicare readmission rates. Medicaid heart failure readmission rates are 29% versus Medicare readmission rates at 23.7%. The sources for this are all cited in the guide in case you're interested. So that when we see that Medicaid adults, younger and middle-aged adults, are at high risk of readmission, we need to think about what are the strategies out there in the field that are being deployed to reduce readmissions for high-risk patients, and to what extent do those strategies need to be adapted to better address Medicaid patients' post-hospital needs. For example, in Massachusetts, a statewide readmission analysis found that fully 40% of all hospitalized adults in med-surg hospitals had a coded behavioral health condition. And that was for all patients, 40% all patients hospitalized in Massachusetts. When we just looked at Medicaid adult patients, the prevalence of a comorbid behavioral health condition was 61%, which of course suggests that as we look to improve transitional care and post-hospital follow-up for Medicaid patients, not only does a general population need to have their behavioral health needs addressed and coordinated, but specifically so for the Medicaid adult population. Similarly, in a statewide analysis we conducted in South Carolina, we found that the diagnosis leading to the highest absolute number of readmissions among Medicaid adults in South Carolina was sickle cell crisis. And when we looked at the list of diagnoses for the Medicare population leading to the most readmissions in South Carolina, sickle cell was not even listed on the top 10. So again, it's a signal to us that as we look to execute a data-informed portfolio of strategies, we want to compare and contrast and look at the similarities and differences between Medicare readmissions and Medicaid readmissions, and we want to think about the ways that the data is telling us that we need to adapt our strategies to better serve the adult Medicaid patients' needs. So what do we need by taking a whole person approach to transitional care? This is the component of our analysis that we encourage you to really connect with the root causes of readmissions and to not over-medicalize root causes of readmissions. We encourage a patient and family-centered readmission review approach as well as a root cause analyses in the guide. And what we have learned from our experience and the experience of our field testers is that the field has found success with transitional care models that address clinical, behavioral, and social needs following a hospitalization, and that many of these models that are being adapted in the field and implemented in the field are interdisciplinary, include social work skills, and social service models in their transitional care work. And we've observed that several so-called clinical approaches that focus on medical follow-up, on medical self-management tasks, are actively adapted in the field to include a focus on social work, navigation, advocacy, and mobilizing resources to address basic needs. We have observed that successful readmission reduction teams adopt a whole person approach as fundamental to what they do, as core to their work. And these successful readmission reduction teams state observations such as, we look at the whole person, the big picture. We always address goals and ask what the patient wants. We meet the patient where they are. First and foremost, it's about a trusting relationship. Quote, you can't talk to someone about their medications if there's no food in the fridge. And finally, quote, we do whatever it takes to address the patient's needs in order to avoid a readmission. So these are the observations and the spirit and the expertise and the talent that we observe in the field, teams that are taking a whole person approach to implementing transitional care. What do we mean by taking a data-informed approach? Well, I've alluded to this in the first part of this webinar, that we observe that many readmission reduction efforts to date have been launched in direct response to Medicare readmission penalties. This is logical, this is good, and this has been important work. As the field changes and as expectations for readmission reduction goes from a certain group of patients with a certain set of diagnoses into larger and larger bodies of target populations and patient populations, it's important to recognize that the discharge diagnoses highlighted through the Medicare penalty program are not the top reasons for readmissions, even in your Medicare population, and that there are many high-risk patients that go without improved transitional care when teams just focus on patients with those penalty conditions. And so we submit to you and encourage you to do analysis that would show you that focusing readmission reduction efforts just on the Medicare penalty diagnoses will not put you on a path to reducing hospital-wide readmission rates. It won't help you reduce Medicare readmission rates overall, let alone hospital-wide readmission rates. And so through the advice in this guide and the work that we've done with teams in the field, we recommend that you start off your use of this guide by taking a renewed look at your data and to adopt a data-informed approach to reducing readmissions. We encourage you to start off by getting clarity around your hospital's readmission reduction goal. Is the goal to get out of a Medicare penalty readmission penalty situation? Is it to do better in other domains of Medicare financial penalties? Does your hospital have other risk-based arrangements for other types of populations? The field is changing so quickly that what used to be possibly a very simple and straightforward readmission reduction goal could be multifaceted now, such that it's wise to start this work, reconsideration of readmission reduction redesign with a new articulation of your hospital's readmission reduction goal. Then move in to analyze your own hospital's data to identify who is really at high risk and what are your unique readmission patterns at your hospital. National data will never reveal to you your unique readmission patterns in your specific market. And then move into some work to understand the root causes of readmissions among your patients, most notably listening to their experiences, listening to the feedback of patients and their families and caregivers who have been readmitted, and listen to what led them down a path to coming back to the hospital, and consider the social, behavioral, as well as clinical needs that were either unaddressed or incompletely addressed that led them back to the hospital. Then design and implement an approach that is designed to effectively meet the transitional care needs of your patients. So if you identify a group or groups of patients at your hospital that are high risk of readmissions and you understand their root causes, then by all means make sure that the strategies you deploy are matched to meet and address those root causes for that target population. And then finally, we emphasize that successful hospitals and success in this work really requires hospital readmission reduction teams to track implementation of the strategies that you'd like to see put in place, as well as track the outcomes of those strategies to inform continuous improvement to reach your goal. This is the key linchpin of all successful hospitals that have reduced their readmissions, is measurement and using that measurement to inform continuous improvement. Every readmission reduction team knows that this is important, but we emphasize this because we know it's perhaps one of the more challenging tasks to do on a day-to-day, week-to-week, month-to-month basis, and it's essential that you have your readmission reduction team set up in order to be able to track implementation and outcomes on a regular basis. So in summary, the ARC Hospital Guide to Reducing Medicaid Readmissions encourages hospital teams to expand readmission reduction efforts to all patients, adapt strategies to better serve Medicaid patients, employ a data-informed approach to designing readmission reduction efforts, and implement a whole person approach to identifying and addressing patients' transitional care needs. The ASPIRE framework upon which the guide is written supports an updated strategic planning process and recommends improving care in a minimum of 3 complementary domains of work, which are improve hospital-based transitional care for all, collaborate across settings with providers and agencies in the community, and deliver enhanced services to patients at highest risk of readmission. Thank you so much for attending this first webinar. We'll look forward to seeing you on future webinars, and thank you so much for your commitment to reducing readmissions. On behalf of my co-investigators, Dr. Angel Burgoyne and Dr. Jim Maxwell at John Snow, I thank you for attending this webinar and have a great day.